Papulosquamous lesions. You should remember like psoriasis, parapsoriasis, mycosis fungoides, eczema, secondary syphilis. In all these conditions, you can see papulosquamous lesions, but basal cell carcinoma does not present with papulosquamous lesions. Now coming to important one-liners from psoriasis topic, it is not a pre-malignant condition. It shows silvery white scaling and Auspitz sign, which is in a sequence of initial scaling, grattage, bulkless membrane, later followed by pinpoint bleeding. All these are seen in the same sequence. Munro's micro abscesses are seen in the stratum corneum layer. It contains neutrophils only, and it is the most characteristic finding of psoriasis. The other histopathological findings are hyperkeratosis, suprapapillary thinning, parakeratosis, and acanthosis. There is irregular pitting of the nails. You should remember that it is regular pitting of the nails which is seen in alopecia areata. It's also called as Scotch blade pattern of pitting in alopecia areata. Other nail findings are onycholysis, splinter hemorrhages, subungual hyperkeratosis, nail plate thickening. Clinically, knee and elbows will show the silvery white scaling. It clinical presence with definite block with clear margin. It is associated with psoriatic arthritis. The most common variant is oligoarticular type. Joint involvement is seen in 5 to 30% of the patients. As I have already told, scaling is typical of psoriasis, but typical scales are absent in groin. Most common site of psoriasis is scalp. Least common site of psoriasis is central nervous system. If in the question it is given that child followed by streptococcal sore throat, if he develops lesions which are raindrop like, then it is gutted psoriasis. Greasy yellow scales on scalp is seen in seborrheic dermatitis, is associated with cradle cap and Parkinson's disease. Coming to treatment of psoriasis, there are various modalities like PUA therapy, methotrexate, steroids, retinoids, and infliximab, the recent biological infliximab. Topical therapy, vitamin D analog calcitriol is present, and remember tazorotene is the first topical retinoid which is approved by US FDA for psoriasis. There are two regimens, Gokerman's regimen and Ingram regimen. Gokerman regime is UVB with Coaltar, and Ingram regime is diethanol plus UVB. Treatment of choice for pustular psoriasis is retinoids, that is acetretin. But if this is not given in the option, then the next best option is methotrexate. Few points about acetretin. It is teratogenic, so it's contraindicated in pregnant women. Patient can donate blood. It has long elimination time. It causes hyperlipidemia. Okay, now some questions where prednisolone can be the answer. You should be in a position to understand what the examiner is trying to ask. For example, drug of choice for pregnant women in second trimester pustular psoriasis is prednisolone. Pustular psoriasis, drug of choice for impetigo herpetiformis is prednisolone. The only indication of giving corticosteroids, that is prednisolone, in pustular psoriasis is psoriatic erythroderma with pregnancy. The only definitive indication of systemic steroids in psoriasis is impetigo herpetiformis. So these are all the different case scenarios where prednisolone or steroids will be the answer. And you should remember this particular scenario where the pregnant woman is also diabetic, associated with lakes of pus, that is pustular psoriasis. Then cyclosporin will be a treatment of choice. Treatment of choice for erythrodermic psoriasis is methotrexate. Psoriasis is exacerbated by certain medications, of which lithium, beta blockers, and antimalarials like chloroquine are important to be remembered and can be asked in the exam. Now coming to Lichen planus. The next important papulosquamous disorder which should be discussed is lichen planus. In this, you should remember that the patient will not present with excoriation marks. As you all remember, the 5 P's of lichen planus, it is pruritic, purplish or violaceous, polygonal, plain top papules. Wickham's striae is the most characteristic finding. Most characteristic histopathological finding is basal cell degeneration. Max Joseph spaces are seen, civet bodies are seen, also called as colored bodies. Acanthosis, hyperkeratosis, pigment incontinence, and wedge-shaped hypergranulosis. All these are features of lichen planus which are to be remembered. And nail shows pterygium, trachyonychia, thinning of the nails. Thinning of the nails is the most common finding. You should remember that it is not thickening of the nails but thinning of the nails which is most common finding and seen in lichen planus. Thickening of the nail plate is seen in psoriasis. Tented nail or pup tent sign is also seen in lichen planus. It will leave hyperpigmentation. The patients will be distressed with the hyperpigmentation which is left behind due to lichen planus even after the treatment. So you should remember that it will not leave hyperpigmentation. Oral cavity shows lacy white pattern. Lichen planus is associated with hepatitis C virus. Topical steroid is a mainstay of treatment in lichen planus. And there is spontaneous remission within 6 months to 2 years, a maximum of 2 years. Lichen planus lesions will show spontaneous remission. Treatment of choice for acute widespread, if it is acute and it's widely spreading, then it is systemic steroids. Chronic lichen planus can turn out to become squamous cell carcinoma. Remember, in examination, in a hurry, you might answer this wrong, so keep it in your mind. Lichen nitidus and lichen scrofulosaurum are not types of lichen planus. Lichen scrofulosaurum, in fact, is a type of cutaneous tuberculosis, that is tuberculosis, which we will discuss later. Pityriasis rubra pilaris, also called as follicular keratosis. There is cephalocaudal distribution and isolated patches of normal skin are found. This is called as napiscleraris. And it will show, we'll call it as PRP sandals. The palmoplantar keratoderma can also be seen in Pityriasis rubra pilaris. And there are certain important nail changes which you must remember. Like in lichen planus, we can see pterygium, but it is dorsal pterygium which is seen in lichen planus. And if the option is ventral pterygium, then the answer will be scleroderma. As already told, alopecia areata shows regular pitting. And malignant potential of oral erythroplasia is the highest, followed by oral non-homogeneous leukoplakia, followed by oral ulcerative lichen planus, ulcerative or erosive type of lichen planus. Oral lacy pattern of lichen planus shows the least malignant potential. But remember that the leukoplakia is the most common finding seen in the oral cavity. Thank you so much for watching the video till this point. Bye.